In this next section of talks, I'm going to be talking about the principles of study design and analysis for case control studies, cohort studies, and randomized clinical trials. It's very important for us to know that the different kinds of study designs are relevant to us in terms of choosing what to do ourselves, but also interpreting everybody else's findings. It's important for us to remember that any research question can be addressed using a number of different research strategies, and we're going to make a choice between them based on our scientific question and our resources, how much time we have, how much money we have, what we can literally do in terms of doing this study. But each study design has its strengths and limitations that must be clearly understood. So we may choose one study design because it's quicker and it's cheaper, but it will usually have some more problems associated with it that we have to keep in mind. It's also important to always remember that no one epidemiologic study can answer a research question definitively. So if we're sitting here today and we're trying to figure out our current state of knowledge about a question that's important to you, we need to consider not just one study, but the totality of evidence that is available on that particular question. And our totality of evidence includes both basic research and epidemiologic studies. The basic research is very important for us to understand how an exposure could impact an outcome. What is the possible mechanism by which it would be working? And so we work with our laboratory and our animal colleagues to be able to get that evidence. But the unique feature of epidemiologic studies is that they're done in humans. So they're complementary to the basic research and really provide us information we would not get from basic research. And one of the first classifications for epidemiologic studies is that they are either descriptive or analytic. Descriptive studies are the ones that basically tell us who is getting this outcome. What's the definition of what they are getting? Does it matter if they are young or old, if they are smokers or not smokers, if we're talking about 1950 versus 2013, if we're talking about a developed country or a developing country? Just describe the outcome that we are interested in looking at. All of those are going to raise hypotheses for us. The correlational or ecologic studies, the case reports and the case series, the cross-sectional studies or surveys are going to raise hypotheses which we will then test in the analytic studies, the studies that are going to allow us to figure out why this exposure is related to this outcome. And the next differentiation is between whether those analytic studies are observational or intervention. Observational studies mean we simply watch what people do. We record whether they have a high-fat diet or not, take a particular drug or not, what their genetic profile is or not, and we look at what outcome they get. But we don't intervene in any way. We just record. In an intervention study, randomized clinical trial, that will be the closest to a basic research study that we can do in epidemiology, because we are actually going to allocate people to either get the intervention or not. So again, the main difference is between descriptive and analytic. We're now going to be talking about the three kinds of analytic studies: to search for factors associated with or predictive of the outcome. There will be observational studies, either case control or cohort, and then we'll talk about intervention studies or the randomized clinical trial. And the key distinction between the observational studies and the intervention studies is the role the investigator plays. So in an observational study, the exposures are self-selected, and we just record what happens. And in an intervention study, the exposures are actually allocated by the investigators. And first, then, we're going to look at the two types of observational studies, case control and cohort. And it's going to turn out that in both cases, we need to know about the exposure status and the non-exposure status, and whether they get the outcome or the disease or not. The only difference between a case control and a cohort study is how we bring people into the study. And in a case control study, our initial classification of our two groups is on the basis of the outcome, whether they got the disease or not. And in a cohort study, the initial selection or classification is going to be on the basis of the exposure status, whether they are exposed or not. We're just coming in at different ends of the exposure-disease relationship. So a case control study is a type of observational study in which the subjects are selected on the basis of whether they do or do not have a particular disease or outcome under study. If they do have the outcome, they are called cases. If they do not have the outcome, they are called controls. And then we take those two groups and we compare them with respect to the proportion having a history of an exposure or a characteristic of interest. And looking at it as a diagram, as we said before, for every single study, case control cohort or trials, we have to know the exposure status and we have to know the disease status by the time the study is over. In a case control study, we are going to start at the end, classify people on the basis of whether they are diseased or not, and then go back and assess their exposure status between the two groups. Let me just give you a few examples of a case control study. Let's say our question is there an association between a baby's sleeping position on the stomach, on the back, and risk of sudden infant death syndrome? So the cases have to be deaths from SIDS. So all deaths from SIDS in infants between the ages of 7 and 364 days, so within the first year, in two regions of the United Kingdom between February 1993 and January 1994, reported through a communication network of professional organizations who report all sudden unexpected deaths. The controls need to be similar children who did not die of sudden infant death syndrome. So what they did is go back to the hospital, the same hospital in which the SIDS baby had been born, and identify the next two younger and the next two older babies who were born in the same hospital within 2 weeks of the age of the index baby, but they did not die of SIDS. So cases were deaths from SIDS, and controls were babies born at the same time in the same hospital who did not die of SIDS, case controls. Another example, the question is, do young women, so women less than 40, who regularly participate in physical activity during their reproductive years have a reduced risk of subsequent breast cancer? So the cases have to be young women with breast cancer. So they got 545 women aged 40 or younger at diagnosis, newly diagnosed with in situ or invasive breast cancer between July 83, January 89, identified by the population-based cancer registry for Los Angeles County. Controls need to be women of the same age who didn't get breast cancer, but we like them to be as alike as possible with respect to everything else besides physical activity. So what they did was go to the house where the case lived at the time of diagnosis and basically walk the neighborhood to find a neighborhood control individually matched to each case by date of birth within 3 years, race, and parity, based on a predefined walk pattern for the neighborhood where the case lived at the time of diagnosis. So what are the strengths of a case control study? Well, this approach actually began relatively recently compared to a cohort study or a trial, as the diseases of interest to us shifted from acute to chronic public health problems. So as chronic diseases have become more prevalent as causes of death, not only in developed countries, but in developing countries, then we had to figure out a way to deal with that. And the problem that we had to deal with is that there was a long latent period between when the person was exposed and when they got the outcome. We all know that it's not what we eat today that's going to increase our risk of developing cancer tomorrow, that what our pattern of diet is will affect our risk of developing cancer 5, 10, or 15 years from now. So there are long latent periods in chronic diseases between adequate exposure and the development of the outcome. And by picking in a case control study people who already have the disease, then in fact it becomes a very efficient design with respect to time and money, because you don't have to start with people eating a particular diet and then follow them for long periods of time until they develop the outcome. You're starting with the outcome. They already have it, so that's going to save time and money. And since we're going to select on the basis of the disease status, we can identify adequate numbers of diseased and non-diseased people. So it's going to be the ideal design when the outcome is rare. We're not going to need to follow large numbers of people in order to get sufficient numbers who subsequently develop a particular outcome. It also allows for the evaluation of multiple exposures or risk factors for a single disease. So I, myself, for case control studies, do it one of two times. Number one, because my disease is so rare that I don't want to have a massively big sample size to get enough people with mesothelioma or a particular other outcome that's of interest to me. And the other time I use it is when I just don't know much about this disease. I really don't have a good body of information about its risk factors. So when I want to understand a lot about the risk factors for the disease, then I pick on the disease. I take people with it and people without it. I can ask them many, many questions to try to elucidate the risk factors for that particular outcome. So when I am interested in the disease and everything that might be related to it, then I pick the disease, which would be a case control study. And it can be used to test hypotheses, but it also can be used in the example I just gave where we really don't know much about this outcome to explore a wide range of exposures. What's sometimes called a fishing expedition, but that doesn't make it bad. It's not a pejorative term. It just means that I'm going to ask loads of questions and see what sort of comes out so that I advance my knowledge and then can test that in another study. So it's particularly useful in the early stages of knowledge about a disease or an outcome. Now, the limitations are, though, that at the time you start the study and you ask people about what their exposure has been in the past, they already know that they have the disease. So if the exposure status, when assessing the exposure status, you already know the disease status, you already know it, the participant already knows it, then there's a real potential for bias in that people being brought into the study are selected differently based on whether they were exposed or not. Or they answer questions differentially because they know that they are diseased or not. So there's the potential for selection bias, which is the selection of cases or controls on the basis of whether they were exposed or not, whether they were smokers or not, as well as observation bias, where the people report their smoking either more precisely or they deny that they do it, one way or the other, but they do report it differently than people who know that they do not have lung cancer. And the other thing that's a little bit tough about a case control study is that the temporal sequence of the exposure and the outcome may be difficult to establish. The logic is fine. Some people say it seems a little artificial. You're going backward. So you have the outcome and now you're trying to figure out what the exposure must have been. But that's not an unusual logic in everyday life to look at something that happens and go back and try to figure out what must have caused it. But what's most of a concern is I don't actually know when I'm supposed to be getting your exposure history. Let's say you now have colon cancer. Am I supposed to be asking about what you ate last month, last year, 5 years ago, when you were a teenager? I don't know when the biologic period is that exposure is supposed to make a difference. And the farther back I go, let's say I do want your dietary history when you're a teenager, are you going to be able to give that to me accurately? So I worry about the ability to both get accurate past information and to know what time period I'm supposed to be getting it for. And finally, because there is no rate of development of disease in a case control study, you either have it, you're a case, or you don't have it, you're a control. Nobody's developing it during the study. Then you actually can't calculate an incidence rate. You can't do a rate of development if there is no development. So you cannot calculate incidence rates in a case control study. But you can estimate the relative risk, the attributable risk, by an alternate measure of odds ratio, which is a valid measure in a case control study. So we get to the measurement we want, but we will never be able to tell people the rate of development of the disease in the exposed and the non-exposed group. If you need that, you have to be doing a cohort study or a trial. So the bottom line, these strengths and limitations or especially the limitations, are not reasons to not do a case control study. They are just reasons to design it very carefully. And the bottom line is case control studies work. It's actually the most common analytic epidemiologic study design in the medical literature. And it's often the first study design that's used in analytic epidemiology. And it's absolutely the optimal approach when we have a new condition that we're interested in, or when we need to do the study a little bit cheaper and a little bit faster than a cohort study or a trial could be done. Well, now we need to go through where do you get your cases, where do you get your controls, where do you get your exposure, where do you get your outcome information. Selection of cases is not usually the difficult part. All we need to do is figure out what outcome you're interested in and define it in a way that can be reproducible by other people. And we really do want as homogeneous a disease entity as possible. You don't want to combine all congenital malformations because no teratogen causes all congenital malformations. And you're tempted to do it because the sample size will be higher, but you don't want to do it because if it's only related to one, for example, of all congenital malformations, one type, you're going to mask your finding that. You're going to harm your ability to find that relationship with one particular congenital malformation type because you have merged everything together and it's going to mask the relationship that you want to see. The same for combining uterine cancer and cervical cancer. Again, the sample size will be bigger, but uterine cancer and cervical cancer have very, very different etiologies, and you will harm yourself in terms of finding the relationship that you want to find. So you'll need strict diagnostic criteria for your outcome, which are reproducible. So you'll need to cite that you use the WHO definition for myocardial infarction or the TOAST criteria for stroke. And then also what you might want to do is stratify your outcome, your cases and controls by definite, probable, and possible so that you really know, did I have all the criteria or just some of the criteria for the disease or the outcome under study. You can get your cases from many different places. You can get them from the hospital, a hospital-based case control study, people who are treated at medical facilities, a hospital, a health maintenance organization, a private practice during a specified period of time. And that's relatively easy to do and relatively inexpensive. You can also do it from the population. You basically enumerate all cases of this disease in a general population or a random, and then take either all of them or a random sample of them. But that's a little bit more logistically difficult because it involves locating and obtaining data from all affected individuals or from a sample of them from a defined population. It's very good in that it avoids bias from selective factors that led someone to use a particular hospital. And if it's complete ascertainment, then you actually can calculate rates, which you can't usually do in a case control study, because now you have a description of the entire picture in the community. But really big logistic and cost considerations, so it is not frequently done. You can get your cases from disease registries or from special surveys, any sort of other source that would allow you to delineate cases of your disease. Couple things we need to think about. Are you going to do incident cases, which are new cases of the diagnosis of the disease, or prevalent cases, people who are existing with this disease? And you'll be tempted to say, let me just use prevalent cases. Let me just go out there and take everybody in my community who has this outcome or disease. But just remember that incident cases are allowing you to only look at risk factors for the development of the disease. Prevalent cases, you are looking at risk factors for not only the development of the disease, but for the prognosis, for the survival from the disease once you get it. And it will be very hard to figure out whether you are getting risk factors for prognosis or survival or risk factors for getting it in the first place. So if you really want etiology or development, if you can, it would be better to use incident cases, not prevalent cases. And finally, someone might say, well, don't I want representative cases? I want a random sample of all cases in the population rather than just using the 5 biggest hospitals in my area. Absolutely will increase generalizability, much more representative of all cases with the disease, but it will really increase your logistic difficulties. So if it is more valid, you will have a better chance of getting all the cases from 5 hospitals than from everybody in your city, your state, or your country. Then go ahead and go for validity. Do it well in your 5 biggest hospitals, and then discuss that, whether it can be generalized to your entire community. Validity comes first. You cannot generalize an invalid result. So do the study well. Do it so there's a valid or true relationship between the exposure and the outcome in whoever you pick to do the study among. And then sit and judge whether it can be generalized or not to a broader population. All right, where do you get your controls? Well, that actually is the most difficult and critical issue for the design and the validity of a case control study. It is necessary, though, to have good controls to allow the evaluation of whether what is observed in your cases is different than what would have been expected to be seen based on comparable people who just don't have the disease. There is no control group that's going to be optimal for all situations. So you really have to think it through, beginning with where did you get your cases. So depending on the source from which the cases were chosen, the controls must be selected to represent not the entire non-diseased population, but the population of individuals who would have been identified and included as cases if they had developed the disease. So it is a comparable population to the population which gave rise to the cases. So again, like the cases, they may not be representative of the general population, but the crucial requirement is that they be comparable to the source population that gave rise to the cases. And any exclusions or restrictions that you made in the identification of the cases would have to also be made to the controls. So the cases and controls have to have the same inclusion and exclusion criteria. So if the cases came from the hospital, then you should consider the controls coming from the hospital. The advantages are that it's very convenient. They're as easily identified as the cases are. They're readily available in sufficient numbers. It's relatively inexpensive to do, and it takes minimal effort because you're already in the hospital anyhow. The cases and controls are likely to be similar in their accuracy of recall because they're sort of both sick. So they're both thinking about what led them to be in the hospital. So it's going to minimize recall bias. And they'll have the same selection factors of coming to the same hospital. And there's generally a high level of cooperation because compared to healthy individuals, they really are sitting with thinking about their health. They're at that moment sort of a captive audience, and they're going to be very willing to talk to you. So it's going to minimize non-response bias. The only disadvantages are actually big disadvantages, or potentially big disadvantages. We have to figure out whether they are or not. These controls are now ill. So they differ from healthy individuals in ways that's associated with illness or hospitalization in general. They actually may not represent the exposure distribution in the population from which the case is derived. And worse than that, it may be that the controls are hospitalized for diseases that are also related to the risk factors under study. We all would know that if you're looking at smoking and lung cancer, you'd never take as your control group bronchitis or chronic obstructive pulmonary disease because those are also related to smoking. Those are sort of obvious. But the more that you are doing a lifestyle factor, like an alcohol and coronary heart disease, can you use accidents as your comparison group? You might be concerned about doing that because car or sports accidents might in fact be related to alcohol consumption. So how can you really be confident that the diagnostic groups that you've chosen as your control group are truly unrelated to the factors under study? And there's also issues about selection factors leading to hospitalization. A hospital may, for some diseases, be specialized. So it's known that you would come to this hospital for cancer or for gunshot wounds, a particular outcome that you're interested in. There's a referral pattern to go there. It's a tertiary hospital. People know to go to that hospital if this is the condition that they have. But for the comparison group might in fact be just coming from the local community, because this hospital treats that kind of a problem just as well as any other hospital does. So the cases and controls may be coming to that particular hospital for a particular disease for different reasons, and that could cause a selection bias. So when the cases come from the hospital, but the hospital controls are of concern to you because they may not be scientifically adequate, or when the cases actually are coming from the general population, then you might want to consider taking the controls from the general population. The advantages of that is that generally that ensures comparability. Everybody's coming from the same source population. But the disadvantages are just logistic. It is often difficult to enumerate all members of the population, and we have to do that to be able to select individuals. Some places like Massachusetts do have town lists where you can get all the names of people living in a community, but most places don't have that. So how are you going to enumerate the members of your population or identify in some reproducible way where your controls are going to come from the population? It's also more difficult to gain cooperation. These are healthy people. They may be working multiple jobs. They don't have time. They're not as motivated to do this. And non-response is always greater than for hospitalized cases, which is a threat to the validity. So all in all, it's going to be more expensive. It's going to be more time-consuming. And it may not have as good quality of information because these healthy people who are living their lives in the community may not recall the exposures as well, or may not be motivated to recall the exposures with the same degree of accuracy as the cases do. Now, there's some special methods to get the controls. There's random digit dialing. We've all received phone calls where we have been selected and we are talking to people after our telephone number has been at random selected. And you can match on area code, you can match on dialing prefix, so you can actually get somebody from the same, restricted neighborhood as you are in. There's a lot of problems with this one. We are by definition excluding people that don't have a phone. And that could cause a problem if socioeconomic status is a variable that's of interest to you. We're going to exclude people without landlines, which may mean we exclude the young, which are less likely now to have landlines than older people do. We have to deal with the probability of being home. So that means we're going to have to call during the day, in the evening, as well as weekends to try to reach people, because the probability of home may be related to some exposures, anything that might have to do with income or socioeconomic status or exercise patterns, anything. We now have answering machines, and people are screening their calls. So you will have less people who are willing to talk to you because if they look when the phone rings, they look at their machine, they don't recognize the phone number, they may not answer. So our response rates are going to be lower now than ever and increasingly low. And finally, the increasing cell phone use is a problem because there are no lists of cell phone numbers. So for all of those reasons, a random digit dialing is still considered, but it is certainly less popular than it was in the past. And finally, something called snowballing, where you take your case and you ask your case to help you find a control. Identify a friend, a relative, a spouse, a sibling, a neighbor who would be willing to possibly be in the study. And actually, those people are much more likely to be cooperative than the general population. And if you needed to control for certain factors, so if you need to control for the current environment, you can get a neighbor. Early environment, you can get a sib. Household environment, you can get a spouse. Genetics, you can get a relative. So it does give a degree of control of important confounding factors that are related to ethnic background, socioeconomic status, current or early environment. But the problem is if the study factor is one for which family members and friends are likely to be similar to the cases, then in fact it's going to make the cases and controls artificially alike with respect to the exposure and underestimate the true effect of the exposure. People tend to eat alike, smoke alike, exercise alike. If one person is big on owning pets, other family members may be big on owning pets. Social interactions. So if the case identifies the control, they actually may identify someone specifically because they might say, well, I have the disease, but my friend has the same risk factors I do and they don't, so pick them. Or my friend has absolutely no risk factors at all, so let's see what it would have been if we did that. Or has lots of risk factors. So they may elect to choose the control based on their exposure habits. That's going to lead to overmatching and absolutely require a matched analysis to take that into account. So, bottom line, the cases must be selected independently of the exposure, and the controls are a direct random sample, ideally, of the reference population from which the cases originated. But just like the cases, they must be sampled independently of the exposure. So how many control groups do you get? 1, 2, more? Ideally, you just want a single control group that is most comparable to the cases. But if there is a situation where it is believed that one selected control group really could have a specific deficiency, and if you took another control group, included a second control group, it might be better, then you can use multiple control groups. So again, if you're doing a lifestyle factor and you really are concerned that there is nobody in the hospital that is not in some way related to this lifestyle factor, then do your hospital control group, but also get a population control group. So multiple control groups when there is a specific deficiency that could be overcome by the inclusion of another control group. And how many controls per case? What's your control to case ratio? 1 to 1, 2 to 1, 100 controls per case? What do you pick? Well, when the number of available cases and controls is large, and the cost of getting information from a case and a control is comparable, then the optimal control to case ratio is 1 to 1. The exceptions are the following. If your sample size of cases is very limited, for example, you have a very rare outcome that even if you work for 2 years to get the cases and multiple sites of hospitals, you can only still get a limited number of them. Or when the cost of getting the information is greater for the cases than the controls, then the control to case ratio should be altered and you should increase the number of controls per case. And as that control to case ratio will increase, your power will increase. But that increased power really levels off at 4 to 1. So 1 to 1 is ideal, but you can go up to 4 to 1 and you will increase your power of your study. The only exception to the 4 to 1 rule is if you are working in a situation where the data are what are called free. So you're identifying your cases or your controls by just going to a health maintenance organization data set or a pre-existing data set of some kind. Basically, you're just putting a request into the computer, give me all people who are matched on these characteristics who were seen in the organization at the same time the case was. Those data are sort of free. It doesn't cost you much to get those. Then you can actually increase your control to case ratio beyond 4 to 1 if the data are free. And sometimes you will see that in a study where they say we got 10 cases per control. We got 10 controls per case. Every time I see that, I know that the control data were just free and they just picked more people. So again, control to case ratio, maximal 1 to 1. Control to case ratio can go up to 4 to 1, and you will see an increase in power. After that, there will be no increase in power unless the data are free, in which case the control to case ratio can go up as high as you want. Now, how do you get the disease and the exposure? Any potential source of information has to be assessed in terms of its ability to provide accurate and comparable information for the study groups. The disease sources can be from death records, case registries, office records, hospital admission or discharges, pathology logs. The exposure sources can be the study subjects themselves by interview or a mail questionnaire, from a surrogate or a proxy, like a mother for a child, a spouse for a dead patient, from information that is recorded in medical records. So the important thing is that the procedures that are used to obtain the information must be as similar as possible for the cases and the controls. If you're interviewing cases and controls, make the place that you go to interview in them and the circumstances the same. Blind your abstractors so they don't know whether the person is diseased or not diseased. The interviewers and the patients should be unaware of the specific hypotheses being studied, so you can blind them to the purpose of the study. And try to train your interviewers the exact same way with role modeling, so they don't use more probing questions for cases, for example, than the controls. And if you can obtain records that are completed before the occurrence of the outcome, that's going to be especially valuable in a case control study. So use birth certificates for birth weight and gestational age. Use prenatal x-rays coming from obstetrics records for congenital malformation. Try to use information that could not be biased by the fact that we all know now that a child has been born with a congenital malformation, or a child has been born with low birth weight, for example. And then, though, the hard part is actually to decide the basis on which a given individual is going to be considered exposed. What part of a person's exposure history is relevant? And to do that, you have to understand the mechanisms of the disease process as well as the likely latent period. So if you're doing smoking and lung cancer, for lung cancer, we know that current smoking is not the main variable to be looking at. It's pack years. It's total duration of smoking and how much you have smoked at each one of those periods of time. But if you're doing smoking and myocardial infarction, then in fact, current smoking is the most relevant. So depending on the outcome, you have to understand the disease process enough to know what exposure history you need to get and at what time period. If the time period is too wide, you use ever use when current use is what is relevant, then you're just going to harm your ability to find the association you're looking for because of random misclassification, which will bias towards the null. What you might need to do if you don't know everything biologically yet about this exposure-disease relationship is evaluate data from differing time windows of exposure so you can begin to look at the time periods and see what seems to be the one that's most relevant with the most increased risk. The analysis, we set up our data in a 2x2 or a R by C table where R is the number of rows, C is the number of columns. As we said before, we can't directly calculate the incidence measures of disease frequency unless we are doing a population-based case control study because there is no development of the disease in a standard case control study. We then estimate the measures of association by the odds ratio, set up our 2x2 table, do the cross-product ratio. Odds ratio is AD over BC. And we can do the risk difference as a percentage. The attributable risk among the exposed group percentage is the odds ratio minus 1 divided by the odds ratio. And we can do it among the exposed, attributable risk with a small e next to it, so among the exposed. Or we can do a PAR, which is an attributable risk among the entire population, percent, either one. A couple of special things then about the interpretation or the analysis of a case control study. And that's back to the role of chance, because many times we're going to do a fishing expedition where we actually derive hypotheses from the data in our study. So most case control studies will test a small number of specific hypotheses. But while you're doing that, you also collect data on a multitude of other risk factors, and you conduct many comparisons besides the ones you are doing as a hypothesis testing situation. So it's very important to distinguish between tests of hypotheses, where those hypotheses were specified in advance, a priori hypotheses, and fishing expeditions, in which you just analyze your data and you see what pops out. How associations emerge when the data are analyzed, called data-derived hypotheses or a posteriori hypotheses. A priori or posteriori hypotheses, they're different. They're different in the way that we must consider the interpretation of the findings. And data-derived hypotheses have to be interpreted with caution. Remember the meaning of the p-value. If you do 20 comparisons and you just see what comes out as statistically significant, remember 1 out of 20 of them will be statistically significant by chance alone, even if the null hypothesis is true. Even if statistically significant, if you are in a hypothesis formulating situation, you have to interpret very cautiously, because any finding that was not specified in advance as hypothesis testing could be due to chance. So these formulated hypotheses can then be tested in other studies specifically designed to do so, but you must say we are raising hypotheses in these studies that could be due to chance and need to be looked at in another study. There's also a special kind of case control study that's very worth knowing about, a nested case control study within a cohort. So in that design, the population is actually defined first, a cohort study, the Framingham Heart Study, the Mayo Clinic study, a study of a particular exposure, a study in a particular geographical area, whatever your cohort is. And as you're following that cohort over time, cases are going to develop and they're going to be identified. And you could use those then as your cases in a nested case control study where your controls are a random sample of non-cases that are going to be selected as your control subjects. So let me give you an example of that. Between 1987 and 1992, there were 10,786 women between the ages of 35 and 69 that were recruited into a prospective study on breast cancer in Italy. At the recruitment, they collected urine from everybody and stored it. After an average of 5.5 years of follow-up, there were 144 breast cancer cases that were identified. And they decided that what they wanted to look at is whether estrogen metabolism affected breast cancer risk. So they took 144 breast cancer patients. They selected about 4 times 576 controls from the cohort who had not developed breast cancer. They matched them on age, they matched them on other variables, and they conducted the study on just these individuals. On the 144 plus the 576, they actually did the assays on estrogen metabolism just among that group, nested case control study. And why did they do it that way? Completely because of efficiency in terms of time and money. Think about it. If the assay costs $25 and you needed to do the entire cohort, then it would cost about $269,650. But if I just did the assay on the 144 cases and between 1 and 4 controls, however many you decided to use, it would cost between $7,200 and $18,000. So much more cost and time efficient way to do it. It also is going to turn out that it's going to reduce the bias that's inherent in a case control study, because every piece of information, the baseline questionnaire and the blood sample, was actually obtained prior to the development of the breast cancer, because it's a cohort study. So at the time that everybody came into the cohort, nobody had developed breast cancer. So nobody knew about whether they would get breast cancer or not when they filled out the questionnaire. So there was a reduction in bias in giving us the exposure information because at that time the outcome had not yet occurred. So reduces bias. It's much more efficient in terms of time and money. So this is very commonly done, especially in these tight financial times. It's an ancillary case control study nested into or grafted onto an existing parent cohort study, where that cohort study becomes a resource for other people to use for nested case control studies. So summary for case control studies, the strengths are they are ideal for rare outcomes. They're not very good for rare exposures because you would need a tremendous number of cases and controls to have enough who had a rare exposure for you to be able to make that comparison. So if your exposure is rare, you turn to a cohort study. If your outcome is rare, you turn to a case control study. If you want to evaluate multiple exposures for a single outcome, so multiple risk factors for a single outcome, you select on your outcome. So you do a case control study. And if you wanted to do multiple outcomes for a single exposure, then you're going to select on the exposure and you're going to do a cohort study. Case control studies are very efficient in terms of time and money. It cannot calculate incidence rates, but you can estimate the relative measures. You have the potential for selection and observation bias, but that will be minimized if you do a nested case control study. And you will always have a difficulty in knowing the appropriate time window for assessing exposure and getting accurate past exposure information, but get it all to the best of your ability, and then you can look at the relationship for different time periods and for different qualities of information and learn from that in terms of the exposure-disease relationship. Thank you.